שלום לכולם, ואני מצטרף לדבריו של זיו ולברך את כולם שהגיעו. אני אציג את האורח, CV עשיר, אבל אני אשתדל לקצר. Dear all, today we have a very special event. Our guest today is one of the international leaders in the field of the head and neck and sarcoma, Professor Brian Osullivan. Professor Brian Osullivan is my mentor during my fellowship in Prince Margaret Hospital, and he helped me a great deal. It's my pleasure to introduce him today. Brian Osullivan is a professor in the Department of Radiation Oncology at the University of Toronto, Ontario, Canada. He also holds the Barclay Smith Walton Distinguished Chair in Radiation Oncology in the Department of Radiation Oncology at Prince Margaret Hospital. He is also a professor in the Department of Otolaryngology, Head and Neck Surgery at the University of Toronto. He received his medical degree from the National University of Ireland at University College Dublin in 1976 and completed internship and general internal medicine at St. Vincent Hospital in Dublin. Additional postgraduate training includes a fellowship in medical oncology and a residency and clinical fellowship in radiation oncology, all at Princess Margaret Hospital in Toronto, Canada. Professor Osullivan is the head and neck oncology program chair at Princess Margaret Hospital and immediate past chair in the head and neck oncology committee of the National Cancer Institute of Canada Clinical Trial Group. He is currently the co-chair of the United States NCI Head and Neck Steering Committee of Coordinating Center for Clinical Trials. He is a recipient of numerous international awards and research grants. He has published almost 350 peer-reviewed papers in excess of 50 book chapters and has written or edited 6 oncology textbooks. He is a commissioner, International Commission of Radiation Unit Measurement, ICRU. He is also a member of the TNM Committee of the Union of International Cancer Control, UICC, chair of the UICC Prognostic Factor Subcommittee, editor-in-chief of the UICC Manual of Clinical Oncology, and representative of the UICC as a liaison of the American Joint Committee of Cancer for Head and Neck Cancer and Bone and Soft Tissue Sarcoma. His interests include sarcoma of the head and neck cancer, transitional research, IMRT delivery, and the principle of image-guided radiotherapy, chemoradiotherapy, and molecular targeting. Professor Osullivan, he's talked today about radiation therapy in head and neck sarcoma. Please, Professor Osullivan, thank you.
This is the first time I've ever been asked to give a talk elsewhere about head and neck sarcoma. But when Salem came to work with us, and we had a great pleasure in having him and other associates, as many of you know, have come to Toronto and know all of our surgeons and our radiation or medical oncologists. I think he was actually quite surprised that half of my practice is sarcoma. Here's this head and neck guy, and he's seeing all this sarcoma, including lots and lots of head and neck sarcoma. So I guess that's why you asked me to give this talk. So thank you very much. I do lecture about it at the university and to the graduates, both in radiation and in surgery especially. So it's not something I had to go terribly deep to get. We have slides on it, so but I did put some new data together that I'm hoping to share with you. It was also a great pleasure in the gathering ahead of time to meet a number of you some people I've not met before, but I've heard about many times: Professor Gold, Professor Gill, also Professor Ben Harouche, and then to meet Fadi, who I might meet again, who looks like very enthusiastic, and many others here. So it's great to get together with all of you. And I can see the spirit of oncology and multidisciplinary care is very strong here in the country. So the framework of the discussion for this talk will emphasize multidisciplinary management, including all the treatment disciplines and all the diagnostic disciplines, and I don't have to name what those are. The staging of the disease is changing. There's a new TNM for head and neck sarcoma, specifically for the 8th edition, that is about to come out this week. So you're the first to hear about it. It will become official in January. The integration of surgery and radiotherapy is a very important part. and that's the focus I will take, but medical oncology is also very important in this whole area. And the various specialties are not just related to what I do, but they include others, including rehabilitation, dentistry, all the social work environment that we have to look after for supportive management of patients, and of course our pediatric specialists. And I have the privilege actually to work in the clinic that I did yesterday morning. Just before I went to the airport, I did the sarcoma clinic. We have all our surgeons there, all our medical oncologists, all our radiation oncologists, and one of them, Dr. Abagupta, is actually does most of her practice at pediatric hospital across the road. It's Hospital for Sick Children, and does the clinic with me every Tuesday. So that's we feel quite proud of having put the program together that way. I also want to talk a little bit about the unique behavior of some subtypes if we actually have any time at the end. And you have to cut me off because we might actually not have time at the end. So please do not feel shy about cutting me off if we get to the end. I don't have a clock here in front of me to know where I am, so we'll just try and do what we can. So this, I took the liberty of, you just heard that I am the editor-in-chief of the Manual of Clinical Oncology, which is part of the UICC's portfolio for knowledge transfer across the world. It's designed for individuals and centers and cancer centers and healthcare workers everywhere in the world to provide a balanced, very usable approach to every single cancer site. Although I noticed that we left out gallbladder when I saw the thing finally. I said, oh my God, we forgot gallbladder. But anyway, every disease is dealt with, plus some principles about management. And of course, I took the soft tissue sarcoma as ours, that we would write the chapter for that, along with my good friend Rafe Pollock, formerly from from MD Anderson, now at the University of Ohio, and former editor-in-chief of Cancer, and a great friend of mine over many, many years. So he's a sarcoma surgeon. And Abba is the medical oncologist who I just mentioned a moment ago. So just to give a few little points, head and neck sarcomas make up 10% of the proportion of cases with soft tissue sarcoma. They're a rare malignancy of mesodermal origin. There are many dozens of histologic subtypes. Fortunately, we can treat most of them the same way because this field is evolving as to what, in fact, are the different pedigrees of the different disease types as the molecular field unfolds, but there are some distinct-ish areas, and we will touch on that a little bit later in the talk. And they are related to the different anatomies as well, which is kind of interesting, that certain types of sarcoma tend to appear in certain areas and not in others. We, of course, see the adult and pediatric variant, and there's a great range of presentation depending on where they originate and what the types of symptoms that they cause are, because, of course, different problems arise depending on where the patient presents with their disease. You need a multidisciplinary team. You need all experts in the various components, and I've already emphasized that, and then an enormous amount of support from a huge array of other people. And I can't overestimate this issue. And I don't even have a slide that acknowledges the team, because the team is so vast. It is gigantic in terms of how our sarcoma program is managed, because the fulcrum is that Tuesday morning clinic, but we have our thoracic surgeons, we have our neurosurgeons who do the spine work, we have our GU surgeons who do the genitourinary sarcomas, and the general surgeons who do work with us, but they don't see enough to come to that clinic all the time. It's mainly orthopedic surgeons and the rad-oncs and the med-oncs. But we have a system where we all come together at the tumor board, which is a vast tumor board that has been in operation for the last 25 years. I started it myself with Professor Bernie Cummings, who some of you may know, many, many years ago, and Bob Bell was a surgeon at the time. And we are very proud of the fact that there has not been a single sarcoma ever managed at the Princess Margaret Hospital that has not been presented at the sarcoma tumor board. They're pathology reviewed and they're imaging reviewed, as well as a multidisciplinary discussion. So it's a very, very important part of the clinic, even though it takes place separately from the clinic. The interval between the symptoms and diagnosis, of course, can vary depending on the site. It's shorter for extremity and head and neck than abdominal, where they can grow very big. And that's part of the opportunity we have when we deal with head and neck sarcomas. And the superficial lesions and those in the head and neck region are usually smaller than those in the retroperitoneum and those originating deep to the fascia. So we should have a good opportunity to manage those because size is a big problem in terms of the prognostic risk of distant metastases, especially in this disease. Unfortunately, despite that, we don't do as well in head and neck sarcoma, at least if you look at the literature. So you get a lot of bad symptoms that you're all very familiar with if you do head and neck sarcoma, or if you do head and neck at all. Many of you are head and neck specialists. All the obstructive and dysfunction symptoms that happen, very disfiguring issues like proctosis and so forth. You get airway obstruction and so forth with mass effect, pharyngeal problems, etc. And the local control tends to be lower in the head and neck than in the extremity, presumably because the anatomy is more difficult and you don't have the options available to you, whether it be with surgery especially, which is the most important treatment, or with radiotherapy as well. Now I tend to disagree with that. I think with a proper multidisciplinary management, you should be able to handle it. We handle other head and neck sites very, very well, and I don't see why sarcoma should be the exception in that. And that's something that has steered the management at Princess Margaret for many, many years, and I'll show some data that I think probably emphasizes or underpins that approach. So just to look at these data, so various histologies, multiple sites, I've already alluded to them. They get different histologies in different sites with, undifferentiated pleomorphic sarcoma, the replacement for what used to be called malignant fibrous histiocytoma being the most common, but liposarcoma, synovial sarcoma, and then another myriad of different groups, but different types of disease. So the rhabdos tend to be more common actually in the head and neck. And the angiosarcomas have an unusual predisposition to various sites, and I will touch on that later. But if you look at these curves here, this is an array of extremity, torso, head and neck, and retroperitoneum. You see that head and neck really does not do as well as it should compared to extremity for local control. These are Princess Margaret data up to 1988, which was at the time when I took over as the head and neck, as the sarcoma site chair. Before I was head and neck of the head and neck group, I was actually the sarcoma guy, which is kind of interesting. These things evolve, I suppose. I guess it was the only area that I could get some opportunity because there were other big leaders in head and neck at the time, and so I decided to do sarcoma as the big area while also treating head and neck. But you can see that head and neck doesn't do as well as extremity. And it also reflects in survival, where you get some unusual behavior. For example, retroperitoneum were dominated by low-grade liposarcomas that eventually claim patients. They do die in the end, 10 years later often, although we are changing that with other treatments. We don't have time to discuss that at the moment. But we still have the problem that head and neck does not do as well as sarcoma, even though the tumors are smaller. And they would tend to metastasize less. And the reason for that is that most head and neck sarcoma patients who pass away from local disease failure, not because of distant metastases. And that is our huge challenge. We need to diagnose them properly. Fastidious thought to biopsy is important. You must know where the biopsy track is to be placed, or where, if you're going to do an open biopsy, place it in the right area. It has importance not just for surgery, for subsequent resection, but also for radiotherapy planning. Especially if you're going to use preoperative radiotherapy, you need to know where that biopsy was, because we do see seeding in the biopsy tract. And this applies to both bone and soft tissue. And whether or not you do FNA, fine needle aspiration, or not is another issue. Some groups, the Scandinavians, have been very, very promotional in this area. They tend to get very good results, but most centers have not used this, not because perhaps they can't develop a good expertise in it, but we often want a bigger piece of tissue for translational research, which is very important to understanding the biology of the disease, and you won't get that with FNA. So we tend to, if we can't get it on a true cut, we will go for an open biopsy. The staging procedures, we use CT if you're looking for bone. The trabecular calcification detail is much better that way. MRI is far better for soft tissue, especially extra-osseous and intraosseous disease. And the other issues you're probably aware of. There are some boutique tests that you might do, bone marrow for Ewing's and rhabdo, CSF assessment for parameningeal rhabdos. Is something that I guess does apply to this current discussion this afternoon, but not necessarily to other sarcomas. And the traditional AJCC, UICC, TNM staging has used this rather strange process of dividing T1 and T2 according to whether they're less than or equal to 5 centimeters, and using grade within the stage grouping, which I don't disagree with this part, but this 5 centimeter business is quite, and it's only 2 T's. One of the only diseases that has only 2 T's. Can you imagine that? And you've got a lot of behavior that happens across it. And it's been a very strong effort to be kind of very conservative with this, you know, rare disease. I don't know why. Whereas other diseases liberally change their staging constantly, to the frustration of many people, especially the cancer registrars and the surveillance community across the world who are trying to track outcomes by stage in many countries. But this disease has basically not changed for, as we would say, where I come from in Ireland, donkey's years, which has been like an enormous length of time. They haven't changed. So we changed that recently. Maybe not in the right way, but as best we could. And this is the AJCC staging manual. Comes out, I think, the 3rd of October comes out, and will become an official publication at the end of October. Will become the new staging with the UICC in January. The UICC book is still out at the publisher, hasn't come out yet, but they are identical, as identical as we can make them, because all sorts of funny little errors and publication issues arise, but they are supposed to be the same. And we recognized in the discussions on the AJCC task force for sarcoma that this disease has been neglected in the TNM for literally 4 decades. Nobody has touched it. 70% of the cases do not even reach the 5 centimeter cut point. We did a literature review and we were not able to find 70% even reaching 5 centimeters. So how can you have a staging system going beyond that? And there are no reports of outcome using TNM because of that, of course, and because it's irrelevant to this disease. So we went to the National Cancer Database in the United States that is applicable to all the Commission on Cancer approved cancer programs in the US, and we asked for data over a reasonable period of time, and decided to look at the data to make up a classification for data collection and demonstration that would happen as time goes by. So this is an opportunity for any of you who want to do something here at a national level to jump in and actually try to get data for the first time at a national level on the TNM, the new TNM. You could even start prospectively collecting it right now if you're a young, enthusiastic person, and have it available in the next 5 to 10 years, because that's what it's going to take. There are no stage groups because there's no data on grade and the T4 to build a model, because here's what we did. We basically borrowed the oral cavity staging system. Jaitan Shah and I got together and decided, listen, why don't we just use the oral cavity and modify it, which is what you have here with the less than 2, 2 to 4, greater than 4, and then with invasions of adjacent structures defined here. The N categorization of N0, N1 will remain. Obviously the M category will remain. And then what is used is the French system for histologic grade rather than the US system, because the French system actually is better. It's a 3-grade system, and it's what is currently used. And we decided to look at the data from the NCDB, the database, to see what we could come up with, at least in terms of size, and the grade that they did have, which was the US NCI 4-grade system, and also looking at whether the lymph nodes mattered or not, because there has been an idea that lymph nodes means you've got distant metastases, which did get changed in the last staging system, and does not necessarily mean that patients are going to die. So one needs to be careful to not condemn them to a stage 4 situation when they may not actually belong there. So here are the data that looks at this. The NCDB was on about 650 patients, and you can see the T's broken out by the size, as you see here. We didn't have anything, we don't have T4s, as I mentioned in the last slide. You can see nice separation in the curves, at least going out to like 4 or 5 years. You can see the nodal situation, N0 versus N1, also nice separation. And you can see wonderful separation by grade with the 4-grade system of the US NCI. And remember, that's not the best staging system, best grading system. The French system is regarded as being a better one. So that's why we can't create stage groups right now. So here's an opportunity for anyone who wants to do a nice paper in the next few years on staging sarcoma, soft tissue sarcomas, that they can actually be the first. We'll probably be the first because we're already working on it, but that's a single institution. A national institution a national database would be good. So what about management of this disease? So here's a nice paper from Rennie Lehman's group in Amsterdam, telling us that survival varies from 50 to 80%. The management is primarily surgical. We would all agree with that. It's difficult to get these margins. The anatomy constrains us, and the prognostic factors are tumor grade, margin status, and tumor size. And they put together the world's literature, both for local recurrence and for overall survival, and all sorts of data that are very consistent that show that grade, margins, and size are quite important. And this paper here by John LeVay, who was my fellow way back, I think he was one of my first fellows actually, is sort of nicely centered here among the data. Here's Memorial Sloan Kettering, Dennis Krauss, good friend of mine. I became a friend of Dennis Krauss. Some of you may know him, simply because of this paper and his paper. The two of us did it together. And notice how similar the data were for the two institutions, Memorial Sloan Kettering and Princess Margaret. And we've never looked back. We play golf together and we have a good time. Here's Quinn Lee from Stanford as well, another good colleague of mine. And again, it's created a lot of discussion over the years as to what is the best way for this rare orphan disease that we're talking about this evening. So if we go into the LeVay data a little bit, it just tells us a few things. The local control is not good in this disease. It should be better. Extremity will be coming in around here, and this is the data up till about 1988. And we were disappointed, and Dr. Pat Gillane and I got together at the time. We do see a couple of things. One is that with radiotherapy, provided you give radiotherapy, a positive margin or a clear margin resection will do very well. They'll both do the same. If you don't give radiotherapy, you're not going to get the same with an R1. But for gross disease, you obviously have a big problem. And that is one of the perennial problems about this disease, especially in head and neck, where you can't escalate the dose of radiotherapy. And I will touch on that later in the talk. So Pat and I got together and we agreed that every single patient, there'd be no more ad hoc management of this disease. Every patient would come through. And by the way, we were not actually even really involved in these other cases at the time. They predated our management, but we still felt that every patient should be sent to the sarcoma clinic through the tumor board and would be seen by a multidisciplinary team with all expertise involved. And it spawned a huge amount of collaboration in this disease, and for better or for worse, it means that if you get a soft tissue sarcoma and you live in Ontario, or maybe even large parts of Canada, you can't actually go through your treatment without me hearing about you. So it's kind of interesting because they all go to me as the radiation oncologist who treats head and neck. And the surgeons all do that. They all refer them, and we come out with an approach to management which obviously respects their involvement as well. But it's a carefully orchestrated multidisciplinary management process where there's expertise in the disease anatomic area as well as in the disease's biology area. Here's an original paper we came in the first period of time up till about 1989 or so. Sorry, about about 89 I think it was. I'm sorry, 89 to 99. We published this paper in the World Journal of Surgery, showing, in fact, with preoperative radiotherapy, and I'm not going to emphasize that pre-op is the only way to approach, because these are selected cases for pre-op, as I will mention momentarily. And many names here, you probably, those of you who are in the field for a long time will recognize. And we showed, in fact, that you can accomplish the same as you can in extremity soft tissue sarcoma. And part of the background to this comes from soft tissue sarcoma elsewhere, which is where we borrow the principles, for example, in extremity. So we published this randomized trial in The Lancet back in 2002, comparing preoperative to post-op, and showed that they're equivalent, that you get very high control rates, and we also had as the primary endpoint wound healing as being the way we derived the sample size for this. But the dose and volume issues were very important, especially effects on bone and soft tissue, including superficial tissues. Here, that's the data showing the local recurrence rates are extraordinarily high, which is the gold standard. Regional distant mets should be pretty good as well, even without chemotherapy. And the overall survival, although we did see a pre-op advantage early on, at 5 years it came together. So we don't want to talk too much about extremity sarcoma, which is what this is based on, the only randomized trial ever done, published in the Lancet, and has basically established practice, I think, across the world, in terms of knowledge at least, for management of this disease. But what we did see, which is interesting, is that the actuarial risk of long-term fibrosis is significantly worse for post-operative radiotherapy that requires bigger volumes and higher doses. And especially the bigger volumes. On multivariate analysis, the bigger volumes that we use to treat around the surgical volumes, all the areas that could have been contaminated, that have been instrumented on, that have drain sites and so forth, result in bigger volumes compared to pre-op, which uses a dose of just 50 gray and is confined to recognize principles of targeting of the area that has the tumor specifically based on clinical examination and imaging. So that has kind of led to evidence-based recommendations for local therapy of soft tissue sarcoma. Peter Pisters, myself, and Bob Mackey put this together for the JCO some years ago and tried to show the balancing act between pre-op and post-op, with the issue about fibrosis and edema and so forth being less, but an increased wound complication in the lower extremity area, but was almost never seen in upper extremity. And it shows the anatomic issues related to vascularity and size of resection and so forth that may actually affect the risk of a wound complication, compared to a much higher degree of fibrosis, edema, larger fields, higher doses, and also patients still get wound complications. Of course you get wound complications. You take a big hole in the patient that has to heal, but it's half of it in the lower extremity, but almost no difference in the upper extremity. So going on into head and neck, we figured at the time that perhaps head and neck could benefit from pre-op in selected situations, and we used these indications. And a lot of people get very excited when we start talking about this because they think we're a bit aberrant. We're one of the only groups that do a lot of pre-op for head and neck. But we choose patients based on the need to maximally restrict radiotherapy volumes in certain areas. So if you're right up against the ocular apparatus, spinal cord, you want to spare the brachial plexus, and so forth, these are good reasons to use preoperative. Because these patients get injured years later. They go blind, they go paralyzed, they lose arm function and so forth. Or if you want to minimize radiotherapy dose in some anatomic sites like the pharynx or the parotids and so forth, which of course all of you know is very important in the long-term survivorship of these patients. Or if you wish not to irradiate new grafted tissues that are vulnerable to high-dose post-operative radiotherapy. So for example, a major reconstruction of the mandible, and then you're going to just bump in 66 gray. Well, it would have been nicer if the rads had been given beforehand and then the resection done. You can avoid that kind of problem when you do that. And as I will show, you don't get that much in the way of wound and other complications with this approach because of the moderate dose. So when we personalize preoperative radiotherapy, I'll just show a couple of examples. Here's a 45-year-old school principal with a Leiomyosarcoma sarcoma of the skull base. He presented with proptosis and optic nerve compression, as well as chiasmal compression, the disease at the back. And John Irish and I saw this man. I think many of you do know John Irish and worked with him or have seen him at meetings and so forth. He's my colleague that I work with every week for the last 22 years. We do a clinic together in head and neck. And we saw this gentleman, and we decided we would give him pre-op. And the reason we gave him pre-op is not that we can spare his eye, and of course I had all sorts of excited ophthalmologists saying, his eye, he's going to go blind in his eye. And I said, I know he's going to go blind in his eye. He's going to go even more blind when we remove it, because his eye cannot be protected. But what we have to do is protect the opposite eye and the chiasm. And that is the key issue that guided the treatment of this gentleman. So he had, it was even in the era prior to us having IMRT, he had stereotactically fractionated radiotherapy at the time, and not IMRT. You notice that he, somewhere around here, he appears in the, no, it doesn't appear. He actually, I guess it was around that time, around 2000 anyway, he finished his treatment. So we were just starting IMRT. But the big issue here is he received preoperative radiotherapy. He did not receive any additional radiation. He had a planned positive margin, and I don't have time to go through the data, but we have found that a planned positive margin, a positive margin is supposed to be terrible in this disease. If a planned positive margin to a very small area where you know it's going to be and you adequately treat it with radiotherapy, we found that has no significance at all on the outcome, either in head and neck or in extremity sarcomas. And we've published several papers on this. So he had the planned positive margin with resection of the optic nerve in this adverse presentation. He also received postoperative chemotherapy because we know from the EORTC study from 1994, Vivian Bramwell's study in the JCO using Cyvadic, the largest randomized trial ever undertaken in sarcoma, up to 550 patients in it, that this actually influences local control in head and neck and torso. So we will generally, in an adverse situation, give chemotherapy. And 8 years later, this patient had no evidence of disease. He's done extremely well. He continued his job. He's now retired. He had incalculable advantage from using pre-op. I could never have treated the volume properly in a post-operative setting without damaging or risking damaging his optic chiasm. And that would have been a risk of bilateral blindness. So the ability to dose spare to the chiasm and left optic nerve was essential here. And the theme here is to recognize that anatomic sites for surgical resection are constrained and doses are restrictive is the key to how you would choose these types of patients. Here's an 18-year-old boy with a preoperative management. He had chemotherapy before and then had adjuvant radiotherapy for a large synovial sarcoma within the masticator space, centered along the ramus, went up to the TM joint and inferior angle of the mandible, and there also was superior involvement up into the masticator space and up into the temporalis muscle. Now, this gentleman was a bit of an odd situation because his parents became frantic. They were actually from some Middle East country, and you could hardly give him his treatment, and they'd take him away for another opinion somewhere. So I think that probably explains why his tumor actually grew while he was getting chemo. But the interesting thing about the chemo is he began to get the septated component to his tumor before we give him his radiotherapy. And he got preoperative radiotherapy, which, as you can see, is designed here specifically to avoid the midline structures with a hard constraint in the IMRT optimization, determined by this blue contour here, where he said that's a no-fly zone for a certain dose in this disease. And we treated him preoperatively, and that was 4 years ago. He has done extremely well, but no evidence of disease. His surgery was undertaken by Pat Gillane and Ralph Gilbert. Some of you know those surgeons. And even though the imaging may not look so great here in terms of his function, he has excellent function and cosmesis following this procedure. So just moving forward a little bit from our own data, and I put it together. I have to especially acknowledge Li Tong and Sophie Huang, who run our Princess Margaret Hospital anthology of outcomes for head and neck. We have a very large prospectively collected data set. At point of care, patients have their outcomes collected by a very formulated process where every patient is captured. And we have about 12,000 patients where we have prospective data. And I think any center in the world could put a database like this together. We just happen to have a lot of patients, so it looks more impressive, but it's been a very rich harvest of information that we got from many, many different sites. And I just asked Sophie and Lee, can you run pre-op sarcomas? Sure. And that happened just after I got the invite from Salem. So here we have 64 cases that have been treated, equal gender. They're usually around 50. They're usually fairly good performing status. They come in with symptoms, of course, and they're in areas that you have big problems with, preferentially in the skull base, as well as in the neck and so forth. We've excluded in this analysis dermatofibrosarcoma protuberans, cutaneous angios, and the alveolar embryonal rhabdos, which have a totally different natural history and biology and different management, and they really are not appropriate to this approach, although we will, from time to time, treat them with pre-op, but not the rhabdos, but the others we may well do that. But looking at this group, you can see the initial tumor size are still on the upper side of these. Some of them are very large. The interval, usually around 6 weeks. That's when we classically do it. 4 to 6 weeks is when we would operate. Some of them get smaller during treatment. Some of them get larger. Some of them don't stay. Some of them stay exactly the same, and some of them don't we don't have the data because the surgical specimen that was acquired doesn't actually describe it. It was fragmented and necrotic disease tumor, so we couldn't actually describe that properly. And the margin status, close, gross, microscopic residual, or with no tumor found. You can see here fairly large groups of each one. And then the important one that many people get excited about is wound complications. And these are defined prospectively, and they are based on a repeat requirement for an intervention, such as drainage, for the use of antibiotics, or for the need for a new operation. And you can see it's not very big. Compared to the extremity, this is almost never seen, really, when you think about it. This is not a common occurrence. Now, there are some situations, if you're up inside intracranial disease, up against when the surgeons have to take dura and so forth, be more careful there, and we'll be very careful about discussing what the implications are. And some of those patients will say, I'm afraid we probably shouldn't do it because that could be a life-threatening complication. But generally speaking, after a discussion, we will go ahead if the type of patient that I've described in the earlier slides has that kind of situation. And you can see the outcomes here. Local control, 89%, far better than the LeVay paper. 5-year overall survival, much like extremity, almost identical in fact. Distant control rates, almost like extremity. Recognizing they are a little bit smaller, therefore they don't do quite as badly. Extremity comes in around 75% for distant failure, and overall survival a little bit lower as well. So you can see the effect of size happening there. They don't have the tendency to metastasize, but the local control, much, much better than we used to get. But you see it's still influenced by the margins. And in fact, as I mentioned earlier, resection margin status doesn't matter at all in this type of planned intervention with the patient already addressed beforehand as to what the plan is and exactly how you're going to address the local disease, with the exception of gross residual disease, which of course is an uncommon situation. Only 5 patients had that, but if you do that with 50 gray, you do have a problem. That patient probably will not get controlled. And the margin status within this range compared to gross is statistically significant. So gross is way ahead, the big issue. Positive resection margin, microscopic, really doesn't matter at all if you're doing it in this context. And that mirrors exactly what we've seen in extremity sarcoma, and we have several papers out on that have actually influenced practice around the world in extremity sarcoma, and I guess we haven't really emphasized it enough in the head and neck area. And by the way, that you probably saw that how do I go back? Must be a way to go back. Yeah, the median follow-up here is long, by the way. This is long follow-up, 6.5 years for this cohort. Now, a little bit of a comment about treating gross disease or unresectable disease. So here's a patient who had unresectable MFH at the time in the right base of skull. And I gave him IMRT to 70 gray, which we don't usually do, but he had no other option. This is a terrible situation. The carotid was a deliberate and barrier to his resection, and I gave him 70 gray, and he lived until he died later of a heart problem. He was an older man in his late 70s. So we got out at least 3 years, probably out to about 4 or 5 years maybe before he passed away. And what it does is it recognizes that the problem really is if you give enough dose, you can deal with it. It doesn't replace doing surgery and adjuvant radiotherapy, but if you can't do those, don't give up on the patient if you can get enough dose in a precise manner that actually can address it. And here's some data from Tom Delaney's group at Harvard, partly treated with protons. We've put it into a book chapter that we wrote some years ago, and showing that small tumors do better with radiotherapy alone. This is unresected tumor. And of course, if you get the dose higher, they use 63 gray. If you got up there, compared to lower doses, they did better as well in terms of survival, and of course, mainly related to local control. So if you can get the dose in a proper way with modern radiotherapy techniques, you probably can cure a proportion of these patients, even if you can't resect them, recognizing that resection is the most important treatment if you can do it. Let's talk about a few of the boutique little diseases now. Angiosarcoma I'm going to talk a little bit about. So this is non-common. It's characterized by proliferating very extensive component of these anaplastic cells derived from blood vessels that permeate through the tissues and the dermis, these irregular blood-filled spaces. And the pathologists will often tell us that the intervening areas between this multifocal aspect, that although it doesn't have tumor, that the tissue is abnormal. They'll say, you know, hey, Brian, this tissue doesn't look right. There's something wrong with this tissue. And I'll say, yeah, it's probably got an angiosarcoma about to happen in it. And the problem is that high risk of local recurrence, distant metastases, and a moderate risk of regional failure pervades the natural history of this disease. It affects a variety of sites, and we, as head and neck specialists, have to bear the burden of one of the more classical, difficult problems that we see. And I'll show some cases in a moment, usually facial and scalp. And we've also got some new data for you on this as well. Post-radiotherapy, classically in the breast and the chest wall. I don't even know if the breast radiation oncologists know that they cause this disease because it happens so late. And we see it. And we see it a lot. I'm treating a patient right now who has it. Right in the chest wall, in the dermal tissues of the chest wall, you'll see this angiosarcoma, sometimes demarcated classically by the portal that was given. So defined. Very, very interesting. And then we do see some rare visceral areas like cardiac sarcomas, but these I guess we can discard as being some kind of anomaly almost. They don't happen in the same, they don't kind of reach the same level that we see with the head and neck ones. And this is the classic syndrome of the post-breast irradiation patient. They're very sneaky, these tumors are, with this multifocal nature, permeating across the scalp. And it defeats the surgical ability to predict where the margin should be, and also for radiotherapy. Very difficult problem. And currently for scalp, we will treat the whole scalp electively with IMRT, and often parotids and upper neck on the dominant side because of the risk of regional lymph nodes. They are actually quite radiation responsive, but they recur unpredictably. Sometimes you think you've done a great job and then they fail locally, although a lot of the time they will be durable. The trouble is they'll fail on the edges of the radiation volume, on the edges of the surgical volume. So you need to have careful decision about how you're going to actually manage each case. And John Irish and I, who's probably seen most of these, have come up with an algorithm that if they're localized disease in one spot that's encompassable by surgery, we will operate on them, and then I will give post-operative radiotherapy to the whole scalp. And we'll put a good, big, nice vascularized graft up there to try and address the issue that I'm going to give a fair dose into that region while treating the rest of the scalp as well. And that's the kind of general approach we do for that. But most of the time, these patients come in with a more diffuse process. So here's a gentleman of mine. He in fact did undergo the resection I've just mentioned. Unfortunately, he recurred later outside of this, notwithstanding the fact that I radiated. But this was in the era prior to IMRT, which we did not have the ability to perhaps to treat as widely as we would wish. And he also illustrates the classic nature of the type of patient. It's usually an older man. It's usually a Caucasian, but this gentleman was Asian. It's rarely seen in black people, and you kind of are tempted to believe that maybe the sun, in some fashion or other, was operating in the background as being a causative agent, because why would older, white, Caucasian males be the most at risk compared to other patients? But that's all a little bit of conjecture, I think. I don't think we have data to be able to comment. And you can see the macular purple area here with the nodules that have come up, and it's really in our interest and in the patient's interest to try and control this, even if they look like they've possibly even metastasized, because this is a huge problem from the management, the palliative management, because you can't control it very easily. Dressings and bandages will not control this type of bleeding. It oozes right through the dressing. So we do go out of our way to try and make sure we give the best option on management. And we've been advantaged a lot by the newer radiotherapy techniques. This is an unusual case. You can see a lesion here, and we treated widely at the time. In the early days of IMRT, he actually went on to develop brain metastases, which were very strange. As a young man, unusual, I don't think a typical version of the disease, as well as having hemorrhagic pulmonary metastases that went diffusely through his lungs. But we did actually get local control. He had surgery by John Irish and radiotherapy postoperatively, and we controlled it. This case here illustrates anyone who's seen one of these cases, the real problems that we have in evaluating it. There's no good imaging technique. Just, you know, you can get the imaging done and you can talk about it and you get MRI and CT and all that and it's all good and PET scanning, but you can't tell this dermal disease, this where's my pointer gone there? This reddish permeating area, and I've wired this area up to try and identify the areas that are not involved overtly, at least, while looking at all of this kind of area all around, and you can see this view looking down at his head showing it. And this man was 89 years of age, and I put it to him. Our medical oncologists were quite keen to treat him with Taxol treatments or taxanes, and that's good. They will respond, but they will come back again. And I didn't see a big advantage to doing that because we still need to radiate him. It's a philosophic issue, and it wasn't like it was going to make it resectable or change what I would have to do or anything. And I talked to the patient, and the patient and their family decided to go with the radiotherapy protocol that we typically do, which is 60 gray in 25 fractions, which is a radical dose to the areas that are grossly involved, and 50 gray and 25 elective treatment by simultaneously integrated boost IMRT. In fact, that should probably be, that's a mistake, that should be about, well, no, actually, that is correct, 50 gray and 25. I was thinking about if we were giving over a longer period. So 50 gray and 25 elective, 60 gray and 25 to the gross disease areas. And we treated the whole area. So this is actually, from a radiotherapy standpoint, quite a technically demanding technique compared to most of the things we do, because in addition to immobilization, IGRT, and image guidance and so forth, one of the big challenges is to get the dose adequate on the surface to be able to treat these tumors. So you'll notice that I've talked about real or painted on or contoured bolus. You notice there's something here at the back, and most people don't really think about doing this, but this at the back, this ledge is actually, is actually real bolus, which is a tissue-like material that we put on the patient to bring the dose up. And the rest of this is bolused by how we put it on the computer and bring the dose forward onto the skin. We don't have time to go into the physics of all that, but those of you who are radiation oncologists and physicists will understand what I'm referring to. But the important message I'm trying to give here is that when you go to plan this patient, you must put the bolus on, which is why it's on the back. When you make the mask and put him down on the headrest, because you can't get it on afterwards. So you must plan him with the bolus in that area, the real bolus, because you're not going to be able to put it in afterwards. So you need to know where that is. That's really what the message here. And you have to be very fastidious about trying to preemptively do these things ahead of time and plan the whole area to manage it. So this patient has had his treatment. He was treated in the spring. Salem may even have known him. I can't remember, but he's done very well. He's had a complete response. And of course, I'm keeping my fingers crossed. I don't truly believe I'm going to control this disease. But he's done very well. They're very happy. They'll be coming back to see me again in December. He was seen quite recently. And whether or not this is useful or not in the long term for a man like this, you can see, however, that we can spare brain and so forth, and we can give the treatment safely and address all these nodules and so forth. And remember what I said about the palliative problems if you don't control it. So likely we will control all of this, and he may well recur at the edges. Although it is interesting that it tends to be defined by the helmet area, as I call it, rather than going further afield. It tends to be very much related to this scalp component. So we just have a paper that's out right now. It's been submitted and the revisions are now pending again. We're sending it back. The reviewers asked us to do one thing, and I'll mention that in a second. But what we've found is that survival is worse for the scalp than the face. And we basically, and here you can see the curves, and they're statistically significant. This is a more historic group. Many of these did not have IMRT. And we defined the management of these according to the principles of surgery and radiotherapy. And we use wide for both radiotherapy and typically for surgery as well, although it doesn't have to be if you're going to use the radiotherapy as well. The surgery and the reconstruction in the resectable localized variant followed by radiotherapy I've already emphasized. It's part of the standard approach that we would take, but many of them are like this man that I just showed a moment ago. You can't do surgery. They will come into this situation here, the third bullet, where they're unresectable or functionally disabling. Even in a small lesion that's involving the eyelid, I don't know how you feel as surgeons who are present today, but our surgeons do not feel they can reconstruct the upper eyelid very well, and we would preferentially use radiotherapy for that situation. And we will also use pre-op where the functional opportunity exists for limited radiotherapy in the localized variant. If it's up against some critical structure, like the eye, for example, would be the most common situation. With these data, you can see that the scalp does better than the face. Sorry, the face does better than the scalp. And I've cured a number of facial lesions that were in, say, upper eyelid with just radiotherapy alone, because they are radiation responsive. And you try to treat them fairly widely, and they don't have the same type of behavior as that one I showed a moment ago in the scalp area. We've been asked to reanalyze the data, taking what they call the palliative cases out of it. And I don't know how we'll define what the palliatives are to see if it truly is a biologic effect that the scalp and face do better. So we'll see how that goes, and hopefully we can get this into press. This is data from Jonathan Bernstein, who was one of our surgical fellows, has now just taken up a consultant position in London with a part appointment at the Royal Marsden. Just a brief word about systemic treatment. I did mention the fact that there are taxane treatments. There's a prospective study on improvement in progression-free survival with taxanes. Other agents like DOX, gemcitabine, and docetaxel have shown median progression-free survival of about 3 to 5 months. Target agents have not really realized benefit, although there's popularity in trying them. There have been a number of groups who've looked at that. And the general comments, this is supposed to be a radiotherapy talk, but adjuvant chemotherapy in the management of soft tissue sarcoma remains controversial, but angiosarcoma-specific trials would be very valuable given the nature of this disease that I've just shown. It will respond, and decisions must be individualized. It depends on the anatomy, the goals, and the inconvenience and/or toxicity. And I think we've already talked about a lot of that already. Let me say a brief word about rhabdomyosarcoma, and I'm talking about the embryonal and alveolar version in the adult. I don't treat the children, so I'm not an expert in that area. I know they do very well, but I see women aged between 25 and 35, usually with left-sided ethmoidal tumors with big lymph nodes. I'm not being actually totally joking here. They usually seem to be left-sided, and they come in with big lymph nodes in the neck, and they have a lesion like this, and they're proptotic. And they do extremely badly, but we do cure some of them, which is what's bizarre. So we don't give up on them. They have a dramatic response to chemotherapy and radiotherapy, so if I could say one thing, be hesitant to operate on them. The big problem for these is that they get leptomeningeal relapse very commonly, and they get bone marrow relapse. They will come in with petechiae, ecchymoses, and a flat white blood count about 6 months after they're finished. And there seems to be nothing we can do despite the most intensive chemotherapy. This is the most troublesome group of patients that I treat in my practice in terms of the toxicity I cause, because they're getting drugs that are like VAC, followed by radiotherapy, interdigitating radiotherapy along with VP16-ifosfamide, which in itself is relatively benign compared to VAC. And then we go on with up to 14 cycles of chemotherapy, and they still get metastases of the type I've described. In women, they can get breast metastases. In young men, they can get testicular relapse. And of course, we have these dreadful problems of the leptomeningeal disease. You can see an example here in a 23-year-old male with this sugar coating thing. The Germans have a word, I think they call it crystal something or other, which is the icing they use on a cake. And you look for this appearance on the MRI, and it's apparently pathognomonic to the radiologists, and there's nothing you can do when this happens. Absolutely nothing. The patient usually goes very moribund very quickly afterwards. Within even a week or 2 weeks, they will become very ill, unwell, and succumb. So it's dreadful, it's very sad, and they're usually young patients. A word about Ewings of the head and neck. This is the data from Rusty Marcus's group at University of Florida. reviewed the Ewing's literature in the American Journal of Clinical Oncology. You can see that local control is not bad. Their data, 11%, that's this series, is local failure, so 90% local control. Survival, not bad as well. Distant Mets is the big problem. Some of them don't report it very well, so they still need chemotherapy as an important part of their treatment. And the question that arises is whether they need surgery in the head and neck. They're an extremely rare tumor. About 5% of Ewing's cases treated at University of Florida since 1965. The German study, big study in Germany on the Ewing's, had about 1% that were Ewing's of the head and neck. The mandible is the most common location, followed closely by the skull, and most commonly presenting symptom is a slow-growing, firm, enlarging mass that can be tender. Here's their data, local control exceptionally high with the statistics as I mentioned earlier. Salem, how am I doing on time here? 2 minutes, all right. So here's a patient of mine, young guy. He came in with a large Ewing's mass of his mandible, had induction chemo, and we did a lot of discussion. I talked to my German colleagues, seen by our surgeons, and in the end the patient himself said, well, why don't you just radiate it? And I radiated it, and he's done, he's now out about 5 years without evidence of any failure. Chondrosarcoma, another unusual area with several classic scenarios, low-grade lesions of the cricoid and the Petro-clival area. Tends to be a disease not managed with chemotherapy, but with surgery, but radiotherapy can be very effective for several situations. So we don't normally radiate the chondrosarcomas of the larynx. This is data from the Mayo Clinic showing that the survival outcome is the same as the normal population in this low-grade one. The only problem is you have to keep removing it endoscopically and or eventually performing a laryngectomy. So in some patients, after they have an endoscopic resection, we will irradiate them if the patient wishes us to do that, because you will control it. The question is that the right thing to do when you've got a survival like this? But it is a survival with a voice that's preserved, so it becomes philosophic. They're very low grade, very slow growing, and this sort of classic phenomenon, they really are a classic. This low grade cricoid lesion is an interesting one. Another classic is the Petro-clival, also usually low grade. And the proximity to critical anatomy makes it very difficult to do a major proper resection. So they are often treated with radiotherapy and have been done so for the last 30 years at the Harvard cyclotron using protons with results 80%. And we've now got a paper out using IMRT that shows very similar results, provided you get the dose adequate. So as I mentioned, the dominant approach should be resection, but radiotherapy can be used for unresectable, especially small volume disease, or for positive margins. Here's an example of a lesion that was resected, was biopsied actually anteriorly on the thyroid lamina, and the lesion was in this location, and we actually gave it preoperative radiotherapy, and John Irish resected it, and he is out 7 years now without any recurrence. This is a grade 2 chondrosarcoma. Which is why we use radiotherapy. Ordinarily, we would not use a radiotherapy for a grade 2 in a resectable lesion, because the grade 2 can metastasize. And just to point out, we have published in the literature about using radiotherapy for the non-skull-based lesions, and have shown that the scenario is basically the same as treating soft tissue sarcoma. You will have local control rates that are exceptionally high with surgery and radiotherapy in the high-risk situations such as positive margins. So don't forget that as an option. What about osteosarcoma? Osteosarcoma is a bit funny in the head and neck. There were 2 simultaneous meta-analyses that came out at this time in 1997. The authors didn't know they were each doing them. One was in the JCO, the other was in a head and neck surgery book. And about 2 years later, they both started talking to each other in the literature. They obviously came across them, and they started debating which one was right or which one was wrong. One came out with the idea that adjuvant treatment is not helpful in osteosarcoma, including chemotherapy, for head and neck osteos. The other one said if the resection margins are clear, it is an important treatment. So who knows what you can do with that. It all comes down to how the meta-analysis was done when they did it. So these are kind of interesting to read these papers and then read the correspondence that came out remotely afterwards, because obviously they didn't know each other were doing the same apparent study. An important paper that you might be interested in is from the MD Anderson, Ashley Guadagnolo's paper, along with Eric Sturgis, showing that if you gave radiotherapy to patients with positive margins, you had an apparent survival advantage, obviously local control, but also survival advantage, but there seemed to be no effect if the margins were negative or clear. So this is an interesting issue, and it is what guides our practice in osteosarcoma. We will treat with radiotherapy post-op if the margins are positive, as well as giving chemotherapy, but we will not do that if the margins are negative. So just to conclude, head and neck sarcomas are heterogeneous. They lend themselves to multidisciplinary care and consultation and management. Combined modality approaches can achieve optimal control in many, with protection of normal anatomy. Radiotherapy is an essential companion to surgery if resection margins are not adequate or not protected by an intact anatomic boundary, such as fascia. Chemotherapy is always indicated in osteo, rhabdo, and Ewing's, and you may come up with your own view about other diseases. Synovial responds well. You saw my case who did get chemo. He was a big synovial. They will usually respond well. You did see some radiologic response. But our own data suggests that it doesn't seem to actually contribute. We have a paper on this in terms of contributing to overall survival. So what we do is we take it anatomically. Can it help the surgeon, is what we will basically. Can it help the radiation oncologist? Can it change the nature of the local disease? Is how we usually look at synovial. And similarly with myxoid liposarcs, which often will respond as well. And I would encourage ongoing trials and research and translational research in this situation. And remember that looking at the staging data, a country like Israel could probably do something to actually come up with one of the first confirmatory studies on the new staging system that's about to be released. So thank you very much for your attention.